Hi, everyone. Morning. We are just about to start the session. So, so I'm Dr. Hafeez. I'm one of a medical oncology consultant. I'm working in Wolverhampton Hospital. There are no disclosures at the moment, so we'll go into the presentation. I will be presenting the early stage small cell lung cancer updates from the ESMO 2024, and my colleague Rubab will be presenting later on the advanced stage updates from the ESMO. So the trials which I'm going to discuss, one few are from the non-small cell lung cancer. It will be generally stage 1 to 3. We will mostly discussing the role of adjuvant or perioperative chemotherapy or immunotherapy, the role of ctDNA with regard to the AGN trial, the JCOG 1914 trial, the 5-year update from the NeoStar and CA209, checkmate 7070, and the most important practice-changing trial, I would say, at the end from the small cell lung cancer, which will be Adriatic, which we will discuss at the end. So generally, this early stage includes stage 3, T1 to up to T4, and N1 and 2. Mostly A and B, and 3 generally goes into the advanced stage as it is not curable. So up till now, there have been established treatment guidelines. In the adjuvant setting, there are multiple trials which have gone. Again, you see that most of these are for the surgery. Most of the surgery has been done for more than 4 centimeter tumor or not. There were a few negative trials like BR31 or Anvil. The positive one are at the moment of Pearls, for which adjuvant pembrolizumab, and IM Power 010 for adjuvant atezolizumab is approved at the moment. It's mostly the disease-free survival in stage 2 and 3A. And as per the NHS and NICE, it can be only offered to the patients who have a PD-L1 of more than 50%. Again, these are the trials which have already been established. We will discuss in detail a bit about a few trials. These are the phase 3 trials in the perioperative non-small cell lung cancer. Checkmate 77T was with the nivolumab. AGN was with the durvalumab. The only thing was that pneumectomy was excluded from the AGN trial. NeoTorch was toripalimab, and Keynote 671 was with the pembrolizumab. This is the one which has recently been approved by the NICE and hopefully will be coming in the guidelines in the perioperative setting. The good thing to see is that all these immunotherapies in the perioperative setting, they do offer a good event-free survival as well as some overall survival. So these are the main phase 3 neoadjuvant/adjuvant immunotherapy clinical trials. The important thing is the pathological complete response rate. If you see, it varies, can go up to 40% in rational 315, or up to at least we can say 17 to 20% pathological complete response rate, translating into the event-free survival as well as the overall survival. So this is one of the posters from the ESMO. It's a very complicated slide. It was just put in to show that because this has recently been approved by the NICE. So it shows that perioperative pembrolizumab in this setting, a few cycles before the surgery and after the surgery, give event-free survival as well as overall survival. We can clearly see the separation of the graphs with the perioperative chemoimmunotherapy. And it can be used in a stage 1 to stage 3B and 2 non-small cell lung cancer. And in the adjuvant setting, once you have given the chemoimmunotherapy upfront, the pembrolizumab will be continued for around a year or 13 cycles, depending upon the tolerability. So the first trial which we are going to discuss is the AGN trial. It has been discussed already. The main thing which we're going to discuss is the ESMO update, where it evaluated the ctDNA clearance during the neoadjuvant treatment with pathological response and event-free survival in the patient with resectable non-small cell lung cancer. Just a bit of a background, it's a perioperative durvalumab and neoadjuvant chemotherapy, which improved the endpoints plus the secondary endpoint of major pathological response. So the event-free survival, the hazard ratio is quite good. It's 0.68. Similarly, the pathological complete response and the major pathological response rates are also quite good, 13% and 21%. Second interim analysis, event-free survival was maintained and remained consistent. We are actually looking at that the pathological complete response rates and the major pathological response rates, these are predictors for improved event-free survival as well as the overall survival, but are only available after the surgery. So we can see that we can only come to know about a pathological complete response or a major pathological response once you had the surgery. So we need some marker to see which patients are going into these responses. And I think a ctDNA measurement during the neoadjuvant or the adjuvant will be a very good marker for that. So this is an exploratory analysis of ctDNA clearance during the neoadjuvant treatment. So the study design, it was early stage disease as discussed, PS0 or 1, lobectomy or bilobectomy, nephrectomy was excluded, and they were and a mutation negative. So the ctDNA was collected at cycle 1, day 1, up to cycle 4, day 1, pre-surgery, and then after the post-surgery in the adjuvant setting. So the biomarker evaluation population, there were multiple endpoints. There were 6 new adjuvant and 168 adjuvant samples. Baseline characteristics were matched, and the pathological complete response rates and the major pathological response rates were higher in the durvalumab arm, which will be expected as compared to the placebo arm, as observed in the overall population. So this, if you see, the overall arms are quite balanced. There are good number of patients in stage 2, stage 3, and stage B, and they were as well as they are randomized according to the PD-L1 expression, and the pathological complete response rates and the major pathological response rates are there. So we now associate the ctDNA clearance with these response rates and its predictive utility. So you see that absence of the early ctDNA clearance may identify the patients who are unlikely to have a pathological complete response rate. In both arms, you see lack of the early ctDNA clearance identified the patients with a low probability of having a pathological complete response with a negative predictive value of 89% at cycle 2, day 1. And patients who had the ctDNA clearance were more likely to have a pathological complete response in the durvalumab arm as compared to the placebo arm. So the earlier you get a ctDNA negativity, the better the chance of pathological complete response. And as expected, it was higher in the durvalumab arm. So in both the arms, you can see that this is the durvalumab arm, this is the placebo arm. So if you have both the ctDNA clearance and the pathological complete response rate, the event-free survival is much higher. If you have a ctDNA clearance but no pathological response rate, no pathological complete response, the event-free survival is slightly less. And if your ctDNA is not clear, you don't have pathological complete response rate, then the event-free survival falls further. The same is for the placebo arm, although the event-free survival is less as compared to the durvalumab arm. So in summary, there were 23 patients who were evaluated, and ctDNA clearance was shown to be associated with the pathological complete response as well as the event-free survival. The patients who had pathological complete response and 93% of the patients who had a major pathological response had a ctDNA clearance by cycle 4, day 1. For patients who do not have this, who do not have achieved the ctDNA clearance by cycle 4, they did not achieve the pathological complete response rate. And we can see that from the graphs before, that the ctDNA clearance resulted in improved event-free survival, and it was more in the durvalumab arm as compared to the placebo arm. So the take home is that if there is an absence of early ctDNA clearance, you may identify the patients who are less likely to have a pathological complete response, and pre-surgical ctDNA clearance alongside the pathological complete response warrants further study as a surrogate for long-term clinical outcomes. So patients who ctDNA was not clear during this treatment have worse outcome as compared to the one who have a pathological complete response. So the next, this is one of the negative studies. It was comparing, it was a phase 3. It was comparing weekly carboplatin with concomitant chemoradiotherapy versus carboplatin and nab-paclitaxel. So it was randomized. Either you can give low dose carboplatin with radiotherapy. The radiotherapy arm was standard. It was 60 gray in 30 fractions. The other was carboplatin and nab-paclitaxel along with the radiotherapy. So the overall survival, you can clearly see in the experimental arm is less. It's 87.3% in the low-dose carboplatin, but 79.6% in the combination arm. Similarly, is the progression-free survival, which is less in the experimental arm as compared to the standard low-dose carboplatin plus paclitaxel, which is, sorry, low-dose carboplatin plus radiotherapy, which is being used at this point in time. So in conclusion, the study failed to confirm the non-inferiority of a combination chemotherapy along with radiotherapy as compared with the low-dose carboplatin. The overall survival as well as the progression-free survival in the experimental arm, the hazard ratio was above 1, which means it was not significant in both cases. Now is the 5-year update from the NeoStar and CA209, which was new adjuvant nivolumab and nivolumab plus ipilimumab in resectable non-small cell lung cancer. So it was a randomized trial. The dosing of the nivolumab is slightly different in this trial as it's a 5-year update now. So it was nivolumab in arm A, 3 milligram per kilogram, or the combination, then surgery, then standard of care adjuvant therapy. Similarly, in the sequential treatment, it was the same thing, surgery followed by the standard of care treatment. The only purpose of this slide to show is the Kaplan-Meier curve. We are no with the major pathological response. We mean that there are less than 10% of the viable tumor cells, and we are already aware of the pathological complete response rates. Patient characteristics were matched in both groups according to the histology. There were majority non-squamous. There was stage 1, 2, and stage 3A, quite balanced, although a bit more of stage 1 and 2 in the nivolumab arm. So the long-term clinical efficacy of the neoadjuvant immunotherapy or with nivolumab or nivo plus ipilimumab showed the event-free survival is quite better. It's around 57.7% at 5 years or 50.3% in the combination arm. Similarly, 70% overall survival at 5 years versus 66.9% in the combination arm. Similarly, patients who received a major pathological response or a pathological complete response derived the clinical benefit. I think it's the same as we have seen in the Asian trial. The better your ctDNA clearance, the better your pathological complete response or major pathological response, the greater the chances of a better event-free survival or the overall survival as is predicted by over here. If you have a major pathological response, you see at 5 years, it's around 74%. And in the overall survival, it's around 81.7%. So this study differed from Asian in the fact that this does not include any chemotherapy arm. It's only purely immunotherapy. Then there was a subset analysis to see which patients did not do good. And it was found that event-free survival by KRAS mutation or STK11 or KEAP1 or SMAC4 status, you see that there is a good difference that if the patient have these mutations, their event-free survival is much less in the nivo arm as well as the combination arm. What I would say is these markers are mostly prognostic. I don't think so they have any predictive indication at this point in time, but I think the more the time passes, the more better it will be to understand how these markers behave in these patients. So in conclusion, the 5-year event-free survival rates are quite high, 7 and 50%, and the overall survival rates are also quite comparable. And patients, of course, who received a major pathological response or a pathological complete response after the neoadjuvant blockade, they derive durable clinical benefit. And if you have any of these mutations like STK11 along with the KRAS mutation or KEAP or SMAC, they are associated with the poor outcomes. The take home is this, that the biomarker devices are used to identify patient subgroups who may benefit from neoadjuvant chemotherapy sparing regimes of immune checkpoint blockade in the resectable non-small cell lung cancer. This is just from the ELCC, not discussed at the ESMO, but it's a very important trial as it compares the perioperative nivolumab with resectable non-small cell lung cancer. It was a phase 3 study, Checkmate 77T. It was a randomized trial. So you see the event-free survival by blinded independent central review. If you have the chemoimmunotherapy, it's much better as compared to the chemotherapy alone. Similarly, the pathological complete response rates are higher as well as the major pathological response rates. It's a good difference in the chemoimmunotherapy arm versus the placebo arm. So majority of the randomized patients completed the protocol cycles. Only 17 and 12% of the patients in the respective arm received 3 or fewer neoadjuvant treatment cycles. The aim of this study is to see whether if we give less than 4 cycles due to any reason, does the pathological complete response rate or the major pathological response rates gets affected. So you see over here in the 4 cycles, there is a good pathological complete response rate of 26%. Versus 18% in less than 4 cycles. But if you see the number of patients are quite less, as more than 80% of the patients, they completed their 4 cycles. Similarly, the major pathological response rates are the same. So you see, even if they're less than 4 cycles, still there are 21.1% of the patients who received a major pathological response rate. So event-free survival is not much difference if you see 4 cycles or less than 4 cycles. If the advantage is still there, even if you have to drop a few cycles just because of the toxicity or patient tolerability. And the time to death or distant metastasis, again, months from the randomization, if you give chemoimmunotherapy, it decreases the time to death or randomization. There is a clear difference between the two curves with a good hazard ratio of 0.62. And no time to death or metastasis by pathological complete response rate and major pathological response rate. I think this is the thing which we have discussed in the last two trials also, that the better you get in terms of a pathological complete response or a major pathological response, the better the survival. So you see in the nivolumab arm, the patients who have a pathological complete response, the event-free survival or time to distant metastasis or death is quite high. Similarly, in the non-nivolumab arm, if there is no PCR, even then the survival is better. Similarly, is by the major pathological response rates. So in summary, the pathological complete response rates or the major pathological response rates were similar among the patients who underwent definitive surgery, regardless of the number of the cycles. And most patients received the full treatment. Around 80% received the full 4 neoadjuvant cycles, and most patients completed the adjuvant nivolumab. So the most important, I think, the practice-changing trial from this ESMO was Adriatic. It was durvalumab as a consolidation treatment for patients with a limited stage small cell lung cancer. So background, why it wasn't required, because there are no major changes in the small cell management for around quite a lot of time, for a few decades now. The survival, even for a limited stage, is not that high. It's only 25 to 30 months, or a 5-year survival of 29 to 34%. So what they evaluated was that let's give the standard treatment of concomitant chemo right to these patients, but randomize them to a 2-year maintenance of durvalumab or durvalumab plus tremelimumab to see how they do better. It's extrapolated from the Pacific trial, which is already a standard of care in the non-small cell lung cancer. So the study design, as we can see, it was an early stage small cell lung cancer, PS0 or 1. They have not progressed through concomitant chemoradiotherapy, and PCI was permitted. The chemoradiotherapy arm was, according to the physician, it can be either 60 or 60 gray over 6 weeks once daily, or a BD dose of over 3 weeks. But the most important thing was that RT has to commence no later than the cycle 2 of the chemotherapy. Then they were randomized to receive either durvalumab or placebo. This was one of the trials which was looking at the dual primary endpoints of overall survival as well as the progression-free survival. The durvalumab and tremelimumab is still under evaluation and will be reported later on. So we'll be looking at this endpoint at this point in time. So the patients were quite balanced. If the one thing you can see is there were quite a lot of Asian patients, around 49%. So even despite this fact, it was quite well tolerated. PS was 0 or 1, and majority of the patients received cisplatin etoposide, but there was a good proportion of the patients who received carboplatin and etoposide also. So they were quite balanced in both arms, durvalumab as well as the placebo. So see the difference in the overall survival of 36 months is 56% versus 47%. But in terms of months, if you just go for the post hoc analysis, at the data cutoff is at 37.2 months. The survival is 56 months versus 33.4 months, which is quite good if you look at the small cell, because you are giving a survival advantage of around 2 years to this patient, which I think means a lot for the small cell lung cancer. And the subgroup analysis, again, the forest plot is favoring the durvalumab arm. The things which are more interesting to see is that even the carboplatin arm, the forest plot favors more the durvalumab arm, which is quite interesting. That as up till this point in time, cisplatin was the standard for concomitant chemoradiotherapy, and then prior PCI again does not impact much. So I think it should be given according to the physician discretion. The progression-free survival in terms of Kaplan-Meier, again, there's quite a good difference of 16.6 versus 9.2 months. And you can see the curves separate quite nicely, and they remain separated at the end. At a 2-year analysis, the progression-free survival is 46% versus 34.2%. Again, the forest plot, according to the subgroup analysis, I think it's the reciprocation of what we have seen in the overall survival, which are with a slightly more favorable in terms of carboplatin as well as in terms of prior PCI. So the most important risk that will come when you have concomitant chemoradiotherapy followed by the immunotherapy is the risk of pneumonitis. So it is not that high. It was there in not 38%, but only one patient of 0.4% was led to death, and 8.8 leading to discontinuation, which is, I think, quite good, which means that at least 90% of the patients will be able to tolerate the treatment or at least go ahead with the treatment. So conclusions, we can have seen a clear difference in the overall survival as well as the progression-free survival. I think this will be the practice changing the moment it will be approved by the NICE and the NHS, and the treatment will continue for around 2 years. I have put two conclusions for this slide because this was another update at ESMO this year. One is I've already shown you about the carboplatin, although the trial was not powered to look into it, whether carboplatin etoposide will be superior to cisplatin etoposide, but it has shown a bit of benefit, which will give physician, I think, a bit more options to offer treatment to less fit patients. And the magnitude of benefit was consistent with the PCI and the RT group. So if you have given the PCI or if you have not given the PCI due to any reason, the patients still get the benefit from adjuvant durvalumab. So any questions at this point in time? If there are any questions, we can take it now or we can take it at the end of the consultation.